We have many new therapies available for severe asthma, and these are very expensive therapies in general. So it's been most important that we understand who should receive these and who will benefit most from these treatments. So it's not just a matter of making sure that expensive treatments go to the right people, but also ensuring that people who really don't have severe asthma can be managed in ways that are most appropriate for the milder severity of their disease. And in the past, we have tended to think of severe asthma quite as if it were manifest by the symptoms people have when they first present. Now, people present with sometimes out of control symptoms. These symptoms can be very severe at the time, extreme breathlessness, but we now know that that extreme breathlessness and wheezing might indeed be simply because somebody has not been ideally managed in the recent past, not been receiving ideal treatments, and indeed they may just have poorly controlled asthma, which can actually come under very good control with relatively straightforward approaches to treatment. So we do distinguish between severe asthma, that is having disease which despite optimal treatment and optimal control of the triggers and the factors that are potentially worsening the asthma symptoms still persists. So a crucial part of determining that someone has severe asthma is making sure that they are being treated with the right therapy and receiving that therapy in the right way. So it's not just a matter of prescribing something, it's a matter of ensuring that a person has an ideal technique with their inhaler. If they don't, then that their inhaler is actually ideal for them, and we can now swap around a number of different devices so that we can be absolutely sure that people are using the best device as well as the best treatment. So let's go to a definition. What would we describe? How do we decide as clinicians whether or not asthma is mild, moderate, or severe? Well, the first thing is we need to confirm the diagnosis of asthma. Is it definitely asthma? So I'll go into this in a moment, but the crucial thing is that some people can present with asthma-like symptoms, and in fact the problem is not asthma, and no matter how much treatment you give those people, they will not end up necessarily getting good control of their symptoms because their symptoms are not due to asthma. So when the diagnosis of asthma is confirmed and comorbidities and problems contributing to symptom severity are addressed, severe asthma is defined as asthma that requires treatment with high doses of anti-inflammatory treatment, inhaled corticosteroids, plus another medication to attempt to control their symptoms, usually a long-acting bronchodilator. And despite having those treatments, the symptoms continue to be poorly controlled. And the crucial thing here is that this refers especially to the pharmacologic treatments, the drugs we prescribe. But there are many other factors that contribute to poor symptom control. And I mentioned the word comorbidities. And comorbidities that can coexist with asthma are diseases or problems that are contributing significantly to the symptoms but need to be treated in their own right because they're not actually the asthma itself. Those comorbidities would include things such as having severe allergic rhinitis, for instance, and very, very troublesome hay fever, nasal obstruction, potentially having obstructive sleep apnea, having gastroesophageal reflux, perhaps having another kind of lung disease, COPD, chronic obstructive pulmonary disease, in people who might have been smokers can be a comorbidity. Other diseases such as heart disease or diabetes can also be comorbidities, and they need to be treated in their own right before we conclude that all the symptoms a person is experiencing are due to asthma or before we decide that a person is on optimal treatment and still has persistent symptoms. So we would also, in the context of thinking about severe asthma, think very carefully about the environment or the setting that somebody finds themselves in. Now, many people might work in an environment that is particularly dusty, for instance. If you're exposed to a lot of dust at work, and we're talking here usually about industrial or commercial settings, not just a little bit of a dusty office. That is a different issue altogether. But if you are exposed to particulates, vapors and gases at your workplace and you're not well protected, or it's not a well ventilated workplace, then you could potentially have an irritant ongoing that is causing you to be very symptomatic. Other ongoing exposures are things like allergens at home. So cats and dogs, particularly if your cat or your dog happens to lie on your bed at night or during the day when you're not there. If you have carpet that's old or your mattress is old and has a lot of house dust mite in it, those are things that can cause you to have continuing persistent symptoms. So when we conclude that somebody has severe asthma, we want to be able to control those exposures as well. We want to know that those things are of much less significance in the overall contribution to the asthma. We don't want to be putting someone on very expensive and intrusive treatments if there are things that could be being done at home or at work to significantly reduce those symptoms and control the asthma rather better. And one of the most important things, of course, that people do, even though they have asthma, in fact, we know that, strange to say, some people with asthma are a bit more likely to smoke, and cigarette smoking is definitely a trigger that can worsen asthma. And somebody who has persistent symptoms, who we are trying to assess for a stepped up treatment approach, we would first of all want to be absolutely sure that we had done everything we could to help them stop smoking and that they had stopped smoking. So we do only define severe asthma essentially when we have determined that these environmental, contextual, social issues are being well and have been appropriately addressed. And perhaps in mentioning social issues, I should mention especially the current context of COVID-19. There's no doubt that people are probably less exposed to some of the factors that can cause their asthma to be worse at present. So not only are we protecting ourselves by socially isolating from SARS-CoV-2, but we are also protecting ourselves from other viruses that tend to circulate at this time of the year. The influenza virus is a very good example of that, but the viruses that cause the common cold are probably the very best, and they are the most prevalent at this time of the year and tend to be for the next few months. And we may well find that people experience fewer colds as a result of the reduced circulation, or at least transmission of these viruses, because we're socially distanced. An important comment here would be an aside really, but a comment about children returning to school. So in case of common colds, the viruses that children most commonly get, rhinoviruses, they swap them very readily between themselves. And as we know, young children especially have a lot of secretions that they don't always control particularly well. And the transmission of viruses between children at this time of the year, or when they return to school especially, can be a significant issue. So we should probably expect, as children return to school, that we will see more common colds, and potentially adults will get them too. This does not mean you have COVID, but it does mean you should consider getting tested, especially if you have a fever, because fever is a very consistent feature of COVID, whereas it is a very, very rare feature of just having a common cold. So that would be one little red flag that you should remember. If the cough, a dry cough especially, is a prominent symptom, that would be another reason, and especially if breathlessness is a symptom. So typically COVID does not cause the standard upper respiratory tract symptoms of a very, very runny nose, heaps of sneezing, and the sort of really prominent upper airway hypersecretion that usually accompanies a cold. So that's just an aside really about COVID and the fact that viruses are common causes of poor asthma control. So let's go to this question of poor control. I've mentioned it a couple of times, and I just want to sort of put this in context of thinking about severe asthma, because we should not decide that somebody has severe asthma until we have determined that these other features are under better control. So we normally consider that people may have persistent symptoms or suboptimal lung function as a result of having poor asthma control. And when those triggers for the poor control are addressed, then their disease may not be severe at all. In other words, they may not need a lot of treatment to control their asthma symptoms and achieve good control. So poor control can be due to poor adherence with medication regimens. So a GP or a physician might have asked a patient to take daily inhaled corticosteroids, for instance, as their preventer medication, or daily inhaled steroid plus a long-acting beta agonist. But the patient may decide to just take that as they think they need it. That would be regarded as relatively poor adherence if they've been advised to take it day by day. And the treatment then would not be to conclude just because they're consistently symptomatic that they should have another step up in their treatment, but rather that we address the reasons why they're only taking it from time to time. Poor inhaler technique I've mentioned, underprescribing, getting it wrong in terms of the severity of symptoms and not giving enough medication, especially not enough anti-inflammatory. And ongoing environmental triggers, as I've mentioned already, allergens, cigarette smoking, other comorbidities that are causing problems. And I mentioned also the fact that patients may appear to have severe asthma or poor control if they have significant comorbidities which are mimicking asthma. So one of the common comorbidities that can mimic asthma is vocal cord dysfunction, and this is a syndrome where there is intermittent laryngeal closure, which can result in severe coughing and extreme and sudden onset of breathlessness, and that can mimic asthma, and it can coexist in people with asthma too. So these are the sorts of things that have to be dealt with, identified and dealt with before we conclude someone has severe asthma. So I guess you're concluding from what I'm saying that severe asthma is a label, for want of a better word, that we apply only when we have decided that other contributors and reasons for persistent symptoms have been dealt with. And that is absolutely true. It is the case that severe asthma is a clinical complex that we really decide on retrospectively. We decide that someone has severe asthma when they're receiving optimal treatment, taking it appropriately, have a correct inhaler technique, and have addressed either the comorbid contributors to their symptoms or the triggers that are actually causing them. So there are differences, therefore, between uncontrolled asthma and severe asthma. And I think before we conclude that anybody has severe asthma, we should determine that not only is their asthma difficult to control, their symptoms are persistent, but that their adherence is good, their inhaler technique is good, and those external triggers are being addressed. How common then is severe asthma? Well, it is not very common at all. The majority of people who present with persistent symptoms actually have mild to moderate asthma. That severe asthma in our community is probably in Australia at a maximum around 5% of all adults who have asthma. So amongst adolescents and adults, it's a very small proportion of people who ultimately will be determined to have severe asthma. So having resolved that a person does have severe asthma, I just want to make a couple of comments about the sort of final resolution of that decision. One is that symptom assessment can be misleading, and it's really important that you do objectively measure somebody's lung function. One of the quite useful things to do when you do an acute bronchodilator test, when you do spirometry, is to ascertain whether somebody has really marked acute bronchodilator reversibility persisting. When I see that, I think to myself, is this person really getting an optimal dose of inhaled corticosteroids? Because normally, as people really do get a decent dose of inhaled steroids, by which we're talking about the equivalent of budesonide 800 micrograms a day or more, or fluticasone furoate 250 micrograms a day or more, then normally you will see the acute bronchodilator response narrow down quite a bit, especially if they're receiving a long-acting bronchodilator, of course, at the same time. So having determined both by their lung function and by their symptom control that a person has poor control or persistent symptoms, and by this we might use an objective measure such as an asthma control test or an asthma control score or asthma control questionnaire. And an asthma control questionnaire score of 1.5 or more, or an asthma control test of 19 or less than 19 is normally indicative of poor control. So importantly here then, having made those objective measures as well as the symptom assessment, we have to decide what we're going to do for the patient. So the most recent guidelines suggest to us that having established that a person needs day-by-day medication, and that medication contains two treatments, a preventer and a symptom controller, so an inhaled steroid and a long-acting beta agonist being the optimal way to address this in the first instance. The next step would be potentially to add another controller, or to step up the preventer medication. And stepping it up from, say, the equivalent of budesonide 400 a day to 800 a day, or even more, is a perfectly acceptable thing to do, remembering that stepping up the inhaled steroid dose at the higher end of the dose-response curve yields very little additional advantage. So once you get to treatment equivalents of inhaled steroids above 800 micrograms of budesonide equivalent a day, you don't see really substantial incremental gains usually in symptom control. But it is a reminder to you to think about all the other things that might be contributing. Certainly you can add tiotropium at this point of time, and then you're giving an ICS LABA and LAMA. And there is good evidence that the addition of tiotropium to moderate dose inhaled steroid plus long-acting beta agonist can be effective in improving symptom control and lung function, and reducing exacerbation rates. So certainly that is a definite step. The next step is now, and some people would advocate that this is done sooner, that you might consider phenotyping the patient. By phenotyping, we're talking here about deciding whether or not your asthma is driven by an allergic type reaction versus a non-allergic type of reaction in your airways. And this can be is essential for deciding on what biologic therapy you might receive. A biologic therapy is a therapy which currently is given by injection, and it mimics proteins that you would make in your own body, which are part of the ways in which we control the inflammatory processes that take place day by day when we encounter things like allergens. So if you are determined to have both poorly controlled asthma, despite optimal therapy and despite optimal control of those contextual things, then you may be very suitable for a biologic therapy. Indeed, some of us would argue that you could introduce biologic therapies at a much earlier stage if they were more affordable. But at the present time, they're very expensive, and the evidence for their benefit particularly applies to people who persistently have asthma attacks and poor asthma control despite optimal therapy. And these asthma attacks we know normally require treatment with systemic steroids, with oral or sometimes intravenous steroids if you're admitted to hospital. And when you have that kind of episode, despite optimal treatment with your inhaled medications, that's when you need to be considered for a biologic therapy. And in being considered, you need to be phenotyped. And phenotyping entails usually doing a blood count, and in that blood count assessing whether or not you have a certain level of eosinophils. These are inflammatory cells which are normally present in our bloodstream, but are particularly increased in people who have allergies and whose symptoms in terms of their asthma may be due to ongoing allergic type stimulation. And so if you do have the right level of eosinophils, telling us that your asthma is primarily this allergic phenotype, or we sometimes now call it T2 high. This is the kind of immunologic response your body mounts to it. Then you would be suitable for a biologic therapy, as long as you have also had attacks requiring oral corticosteroids and you have persistently poor asthma control, and all these other issues have been determined. So once that occurs, your GP may well consider it's appropriate for you to be sent to see a specialist, advised to see a specialist, to be absolutely sure that there aren't other things that can be thought about in terms of getting your asthma under good control, and often sometimes to objectively test your lung function in a respiratory laboratory where you can have some detailed lung function tests, which can be immensely helpful in working out whether or not your asthma can be better controlled. Crucially, these therapies, another type of therapy is what we call an anti-IgE therapy. It goes by the name Xolair in its trade name, and Xolair is appropriate also for people who have allergic asthma but have a particularly elevated IgE level in their blood. So IgE is the immunoglobulin you make in response to allergens, and it's part of the mechanism of allergic inflammation, and we can block it with this particular medication, and that can greatly reduce the allergic manifestations of your asthma. And so your blood test will often also entail an IgE level. It's a very, very simple blood test. Now, there are other ways we can phenotype asthma, and indeed we do phenotype it different ways at specialist level oftentimes. But these are the crucial tests that you have to determine whether or not you would be suitable for a biologic therapy. The other biologic therapies that I haven't named, Fasenra and Nucala, are two what we call anti-IL-5 medications, and they work particularly on the eosinophil pathway that I've mentioned, the allergic pathway which is characterized by eosinophils. These therapies, the anti-IL-5s, are a little bit different in that they affect slightly different pathways, and one of them, Fasenra, is given 4 weekly for the first 3 doses, but then 8 weekly. So it's an 8 weekly treatment given subcutaneously, and the Nucala is given ongoingly, 4 weekly or monthly. Xolair, the treatment I mentioned before, is given depending on the level of IgE in your blood and your weight. So that's calculated to be either a 2 weekly injection or a 4 weekly injection. And we're moving to the point with all these medications that they will be able to be self-administered, and this is a great step forward. It's really important with these biologic therapies that, first of all, your first injections are supervised. And the reason for this is there are some very rare reports of hypersensitivity reactions, intense allergic reactions that we're you can get swelling of your face and lips and eyes and even your throat. So it's crucial that the first injections are supervised. Currently they're supervised in specialist units, but there's no doubt that a GP could supervise these injections too. It requires you staying in the surgery for 2 hours afterwards and making sure that you're perfectly well after your first and second injection. And then if you tolerate them without a problem, and really 99% of people do, then you can continue to receive your medications as scheduled on a monthly or 8-weekly basis. Finally, to say about these injections is they do not have many side effects. They are very well tolerated, and we have found that they are highly successful in reducing asthma attacks, the frequency of asthma attacks. So the people who are most suitable for these are people who continue to have frequent asthma attacks requiring oral corticosteroids, as well as having day-by-day poor asthma control. But the thing that really gets better, their asthma control day-by-day improves a bit. Some people very markedly, others not very much. But the attack frequency certainly drops off. And indeed, we have to demonstrate by close supervision over the first 6 months and then subsequently every 6 months that you really have gained benefit from these treatments, because there's one thing for sure: the government is not keen to provide a very expensive medication to people who are getting little benefit. And these treatments are highly targeted at particular pathways, and some people that pathway is very active, and other people it's not. And so just because you have severe asthma doesn't mean you're necessarily going to gain benefit from these treatments. That's why we try to identify the people who will, but then we must make sure that they do well. And if they are not getting benefit, then the treatment won't be continued, because it's not appropriate for you to receive a treatment that is not helping you. And so that's our approach at the present time to severe asthma. You might have thought that I might mention severe asthma attacks. Now, asthma attacks can be very severe without you having severe asthma. That seems a little bit of a paradox, but it's absolutely the case. You may have relatively mild or moderate asthma, which can be brought under very good control with the right inhaled medication, just with a preventer and long-acting controller, such as long-acting beta agonist. So, in many instances, severe attacks actually are actually best treated in the longer term by low to moderate doses of inhaled therapy, and you never need to step up to this point of severe asthma management using potentially a biologic therapy. So I think that's all I might say for the time being, and if there are some questions, we can perhaps take them. I can't hear anybody, but I can see some comments, and I can see some answers to those comments, and so perhaps I should see if anybody can hear me. I hope you can all hear me. I see there is a question actually, and I'd like to address this. It's about frequent use of reliever, and I totally support the answer here that's being given by Asthma Australia. Really, people who have well-controlled asthma, so we have a very clear definition of well-controlled asthma. So people with well-controlled asthma have very infrequent symptoms, usually less than twice a week. Any asthma symptoms less than twice a week. No nighttime waking. No morning chest tightness on first getting up. No limitation of day-by-day usual activities. And no asthma attacks. That's well-controlled asthma. And that's what we're aiming for when with any person with asthma. We're aiming to get to that point. Now, what that means is you should be needing your reliever medication less than 2 times a week, less often than 2 times a week. If you need your reliever medication 2 times a week or more, then it's quite possible your asthma is not as well controlled as it should be. And the treatment for that is to go Well, the first step is to go to your GP and say, I'm using my reliever medication 3, 4, 5 times a week, twice a day, once a day. That's too much. And that tells us straight away that you need to be reassessed to determine whether or not your current treatment's ideal, whether there are things in your environment that are causing problems, and whether in fact there are better approaches to getting your asthma under control. Your reliever should be something you just fall back on every now and again. And if you have an attack, unlucky enough to get a cold and a viral exacerbation of your asthma, a flare-up that is triggered by a cold, that would be one of the commonest causes, then of course you use your reliever more often. But day by day you should not be using a reliever any more than twice a week. And even twice a week, I'd say, we could probably do better than that. Good. Somebody's told me they can hear me. That's wonderful. I just can't hear them. I can see some comments here, which is very nice. Yes, my positive patient experiences. I see a couple of questions which I can certainly try to answer. One, I do have positive experiences of biologic therapies, but I don't think they're not a miracle drug for everybody. I think it's most important that people recognise that biologic therapies are great treatment for the people who have the pathways that these therapies specifically target. But asthma is what we call a heterogeneous disease. There are a lot of different contributors in different people. And so some people will not benefit from biologics at all, and they can sadly have quite severe asthma. Indeed, you can have very severe asthma and not be suited for a biologic therapy. And for us as physicians, it can be very, very disappointing that people who we know are doing absolutely everything for themselves and for their asthma and absolutely adherent with all their treatments, there's still some people, perhaps up to around 50% of all people with severe asthma will not be suitable for the biologic therapies we have available at the present time. So that's a, one of the tough parts of asthma management at the present time for us as clinicians and for some patients. I was going to make a comment. There's a question about, is brittle asthma the same as severe asthma? Not necessarily, though. We probably don't use the word brittle asthma anymore quite as readily as we used to, because oftentimes brittle asthma is really just poorly controlled asthma. Poorly controlled asthma is when you have symptoms despite, and those symptoms vary a huge amount day by day. Now, almost always we will find reasons in the environment, or poor adherence, or poor technique with an inhaler that partially explains that intense day-to-day variability. It's very, very characteristic of poorly controlled asthma to have highly fluctuating symptoms, and it's very characteristic of well-controlled asthma to have very stable symptoms. So I would not use the word brittle asthma very often these days, and most often if I thought it was present, I'd be looking for reasons why. I was going to make another comment. I think there's a question about exercise, and yes, exercise-induced asthma, we generally do advise people who have troublesome exercise-induced asthma to take their Ventolin immediately before they exercise, and that dose of Ventolin, or whatever you take as your bronchodilator, would not be counted as your Ventolin use for the week. However, I make a comment here, and that is that if you're on the right dose of preventer, nearly always you will not get exercise-induced asthma nearly as often. So if you're getting frequent exercise-induced asthma, I'd talk to your doctor. I think it might be time to sign off. I think I've probably done my time. Thank you to everybody who listened to this Facebook Live session. It's my first, and so I'm sorry if there were technical glitches and it all seemed a bit weird, but hopefully this was helpful for you, and good luck everybody with your asthma through this winter. Just be remembering that viral triggers, common cold, not just COVID, can cause you to get worse. In fact, my final parting comment to you will be that people with asthma are not overly represented in amongst the COVID series that have been published internationally. There is now a large number of series of patients who've had COVID from the US, the UK, Italy, and China. And one thing that we've noted very importantly is that COVID does not appear to affect people with asthma any more commonly than others in the community. So asthma does not seem to be a predisposing factor for getting COVID. You are at risk just as any community member is if you have contact and you're out and about. So you must observe all the social distancing rules, all the hand washing rules. Do not put your hands to your face. However, you are not, as a person with asthma, more likely to get COVID than a person without asthma. The second question is, if you have asthma and you get COVID, will you have a worse episode of COVID? Possibly if you have very poorly controlled asthma, yes, but not necessarily just because you have severe asthma. Again, we haven't got enough numbers to really say this with certainty, but we're not seeing people with asthma as very highly represented in the intensive care series that have been published. So I think, again, I'm quite encouraged by this. I think we've got to learn more as more series are published, but we are definitely not seeing asthma as a major problem when COVID occurs. The third question is probably the one most pertinent to you all. Can COVID, just like any viral infection, cause your asthma to exacerbate or flare up? Well, first of all, it's probably a bit more likely if your asthma is not well controlled. So go to your GP, make sure your asthma is well controlled. You're on the right treatment, taking it in the right way. However, any viral infection, it seems to be capable of causing a flare-up in asthma. However, again, we really did expect COVID would be doing this much, much more than it seems to be doing. We've again yet to see the ultimate numbers for this, because many of those asthma flare-ups would not have necessarily presented to hospital. If you've got asthma and you get a flare-up, you might think, I can manage this myself. I can go to my GP. I don't want to go to one of those hospitals where there's COVID. So we might not be seeing the true picture as yet, because a lot of what we're seeing being published at present series all from hospitals. We're not seeing community series as yet, and so I think we've got to be a bit wary of that. But I would want to reassure you all, COVID does not seem to be the major problem for people with asthma that we feared it might be. Yes, it's an issue for the whole community, and certainly important for you to ensure your asthma is well controlled going into the season of winter viruses. Thank you very much. Bye-bye.